Hi, everyone. Welcome. My name is Katie Grogan, and it's my pleasure to welcome you to the second lecture in our 10-part series, Advancing Health Equity with the Medical Humanities. This series was developed in partnership with New York University, the NYU Grossman School of Medicine, and the Arnold P. Gold Foundation. Our initiative is part of the Gold Foundation's Gold Human Insights webinar series, and we want to express our deepest gratitude to the Gold Foundation for their support and collaboration on this project. I also must thank my partners in the development of this series, Dr. Kim Adams, who is an American Council of Learned Societies Emerging Voices Fellow at Stanford University, where her work focuses on public humanities and medical humanities, and Sharonik Bosu, who's a PhD candidate in English at NYU, where he focuses on economic thought, literary rhetoric, and public humanities. We're absolutely thrilled to have with us tonight Dr. Perri Klass, Professor of Journalism and Pediatrics at NYU. She writes the weekly column, The Checkup, for the New York Times Science section, and has written extensively about medicine, children, literacy, and knitting during her career. Her new book, The Best Medicine: How Science and Public Health Gave Children a Future, is now out in paperback, and it gives an account of how victories over infant and child mortality have changed the world. Dr. Klass is the recipient of numerous awards for her work as a pediatrician and educator, including in 2016 when the American Academy of Pediatrics honored her with the Arnold P. Gold Foundation Humanism in Medicine Award, citing her impact as medical director for Reach Out and Read, a national early literacy program. Her talk tonight is titled Living to Grow Up: Progress and Persistent Disparities in Infant and Child Mortality. And we're excited to have Dr. Klass with us live for questions and discussion following the lecture.
The best healthcare is compassionate, collaborative, and scientifically excellent. Thank you for being on this mission with us to ensure humanism in healthcare for all. This is a Gold Human Insight webinar produced by the Gold Foundation and its partners.
Hello, I'm Pia Pine-Miller, Senior Director of Strategy and Business Development for the Gold Foundation. The Gold Foundation created the Gold Human Insight webinar series to bring inspirational live and pre-recorded webinars to healthcare professionals and learners. Our 2022 theme is Renewing Our Commitment to Humanism. With the myriad of challenges facing healthcare systems today, including patient disconnection, clinician burnout, and even more challenges highlighted during this time of the syndemic of COVID and social justice issues, the Gold Foundation's vision of a better future remains more urgent than ever. Today's Gold Human Insight webinar is one in a series that is part of a special collaboration with NYU School of Medicine, which is an institution that is a member of the Gold Partners Council, a group of medical schools, hospitals, and healthcare systems that are leaders in humanism in healthcare. Thank you to our presenters and our audience for everything that you do.
Today's lecture is the second in a 10-part series on advancing healthcare equity with medical humanities.
These slides provide a description of the larger series and accreditation information from the NYU CME office. They are required for attendees seeking CME credit and are available to all who are interested through the Gold Foundation website.
Hi, my name is Perri Klass, and I am a pediatrician by training. I teach in the medical school and in the Journalism Institute at NYU, and I'm going to talk to you about changes in infant and child mortality, both progress and persistent disparities in infant and child mortality, especially over the course of the last 150 years, most especially in the United States. When I call this talk Living to Grow Up, what I want you to think about with me is how we began to take for granted that children could and should and would live to grow up. I'm going to show you this graph several times during the talk. It's a graph put together by the CDC, which traces infant mortality, which is the number of children out of every 1,000 live births who don't live to see their first birthday. So it's children dying in that first year of life. And it tracks those numbers in the United States from 1915 until the end of the century. And it starts in 1915 because honestly, that's when we really started counting and counting in this way. And as you can see, it's a pretty stark and dramatic graph that takes us from the time that my grandmothers, say, were walking around in New York having their own children, my parents in the teens and the 20s of the 20th century, up till the time that I trained, which is at the end of the century in the 1980s in pediatrics. And what I want to point out to you is that by the end of the century, we had come collectively to feel that children should not die. And this is a handbook on palliative care for children that was put out by the National Academies in 2003, which says on its first page, even though it is a book about palliative care and end-of-life care for children and how to make it better, says on page 1, although dying is a part of life, a child's death in a very real sense is unnatural and has a devastating and enduring impact. And I agree, I'm a pediatrician. I want to talk about how that happened and what it meant for that to happen. And I would also bring to your attention a quote from the director of the CDC testifying in Congress about the importance of giving COVID vaccines to children, asked about, quote unquote, only 400 pediatric deaths at that point, and her response, children are not supposed to die. And what I want to talk to you about is how that came to be something that we all believe can be and should be true. It wasn't true all through history. Here's a quote from a comfort book published back in the Renaissance in England, published as a manual of religious comfort for parents and warning them about the perils that some are suffocated in the womb, others crushed to death in the birth canal, snatched away in the cradle, mowed off in the May of youth. And what the moral is consider that a duke or a prince lends you a dainty, sweet picture of exquisite workmanship, asking you as a parent, are you going to pout and take on as if you've been injured when after some years that duke or prince redemands that picture? In other words, when the deity calls back the child who has only been lent to you. And here, fast forwarding a couple of centuries and jumping over the Atlantic, here's Henry Wadsworth Longfellow in 1848 with a poem that called Resignation that begins, there is no flock, however watched and tended, but one dead lamb is there. There is no fireside, howsoe'er defended, but has one vacant chair. And he wrote this after the death of his beloved daughter, who died young in 1848, Fanny, and he missed her deeply. And you can see what he wrote about missing her and how he longed to see her, and also how her mother wrote about her. It was not that they didn't love her, not that they didn't miss her, but all he could counsel for parents was in the title of the poem, Resignation. And the last example that I'll give you from literature is from Charles Dickens, who had 10 children, one of them his little daughter, Dora, named after one of his characters in David Copperfield, died very suddenly when his wife, their mother, the children's mother, was out of town. And he wrote to her, not telling her that the baby had died, but trying to prepare her by telling her that little Dora was suddenly stricken ill. Mind, I will not deceive you. I think her very ill, though in fact he is deceiving her because the child is already dead. But look at what he counsels her. Remember what I have often told you, that we never can expect to be exempt as to our many children from the afflictions of other parents. So he's telling her, reminding her that this is an inevitable part of being a parent, as it was. And since we're thinking here about disparities and persistent disparities, I'm going to offer you what, let's call it a convenient sample of those with privilege and power. Here are the United States presidents from the first 100 years after there started being United States presidents. And what you will see is that every one of them who had children lost at least one child. So even if you were a person of privilege and of power, it was not at all an unexpected or remarkable thing. In fact, it was more routine than otherwise, that if you went around a table, even if the people sitting at that table had all been the presidents of the United States, every one of them would have lost a child, every one of the ones who had children. And here's a quote from John Quincy Adams, who would go on to be president, was the son of another president, who was the ambassador to St. Petersburg, where his daughter died. "We have lost our dear and only daughter," he wrote, "as lovely and promising a child as ever was taken from the hopes of the fondest parent." He goes on to say that she had been very healthy. She had 6 teeth, but when she was teething, very soon after being weaned, a very dangerous age, and we'll come back to this later, she was seized with a violent dysentery and died. And so I offer you this, and we'll come back to other examples, just to say that there was no protection, not wealth, not power, not being a member of the privileged group. To remind you of some numbers, the infant mortality rate is the number of infants who die before reaching 1 year of age per 1,000 live births. The under 5 mortality rate, again, is the probability per 1,000 that a newborn baby will die before reaching the 5th birthday. And if you want some global numbers for context, in 2019, this is before the pandemic, the global under 5 mortality rate was 38 children out of every 1,000 born alive around the world died before the age of 5. That had been more than cut in half since 1990, when it was 93. And again, I've given you some general numbers to consider. And what I'd like to point out to you is that of that under 5 mortality, a great deal of it, the preponderance of it, is happening in the first year of life, that most of the global child mortality that we're seeing is infant mortality, and that a great deal of that is newborn, neonatal mortality happening in the first month of life. And then by comparison to that under 5 mortality rate, I will show you the infant mortality, the under 5 mortality rate in the United States in 2018 was 6.89 deaths per 1,000 live births. And again, we'll drill down on that a little bit more and look at the disparities, but in that overall rate, again, the infant mortality was 5.7 out of that 6.89, and the neonatal mortality was 4 out of that 5.7. So you're seeing the same pattern there, that many of the children who do die are still dying in the first year of life, and many of those in the first month of life. If we look back historically, what we see again is that through most of history, infant and child mortality was extraordinarily common by our standards, and that as we reach back, we're probably talking about mortality rates of 40% and up, and that it does decline before the 20th century. There are advances, there's smallpox vaccination, there's a great deal of important advance in hygiene, sewage, how cities and communities handle their garbage and their waste. But again, you see a very dramatic drop as we cross into the 20th century. I'm going to show you a couple of really great graphs put together by Our World in Data. And I want you to just look very quickly over time at what happens around the world. If you look at child mortality in 1800, you see that it's really high everywhere. You see, by our standards, dramatic death rates everywhere in the world, as far as we know. If you forward to the middle of the 20th century, you begin to see really stark differences. You see that child mortality in some parts of the world, in North America, in Australia, in some parts of Western Europe, has dropped to rates that we would still think of as high, but that are much, much, much better than they were, whereas some parts of the world are still seeing those very high rates that you saw before, and many other parts are somewhere in between. If we forward again to 2015, you'll see that in the parts of the world where it had already come down, it's come down even further to the kind of rates that I was showing you before. And you'll see that overall around the world, there are still those disparities, but as you might have guessed from what I said about what's happened just since the 1990s, they are not as dramatic and as stark as they were in the middle of the 20th century. So again, coming back to the United States, showing you this graph, what I want to say to you is that in 1915, even in 1920, when my grandmothers were having their children, if you went around the table, again, if you're losing at least 100 out of every 1,000 live-born children, and most people are having more than one pregnancy, which they were, again, if you go around the table in almost any socioeconomic group, you're going to encounter almost everyone will have lost a child, lost a sibling, known somebody well who lost a child. It won't be very far away. That said, it has always been also connected to socioeconomic status, nutritional status. So if the most privileged groups were losing children at the kind of rates that we're talking about, we can talk together and think together about what was happening among the poor, among the marginalized, among the less privileged. And here is a graph from the second half of the 20th century, from 1950 to 2018, looking at the child mortality in the United States. And again, you see a very dramatic change happening over that second half of the 20th century. Now, there have always been marked disparities in the infant and child mortality rate for some of the reasons that I've talked about, and we'll talk about some more. And there are still in this country very dramatic disparities. So that when you look at the infant mortality rate, the number of children out of every 1,000 live births who do not make it to their first birthday, you will see that it is more than twice as high in the African American community as it is in the white community. You will see that it is higher in the Native Hawaiian or other Pacific Islander population and in the American Indian or Alaska Native population, again, dramatically higher than it is in the white and Asian population. And this, to give you a little bit more detail, breaks those mortality rates down into infant rate mortality rates, those dying by the first birthday, neonatal in right around delivery, and then that first month of life. And again, you'll see that across the board, the early deaths are a very dramatic piece of all of those disparate and unequal mortality rates. If we look at the data that has been found historically for mortality, specifically in the American Black community, one of the striking things that you will see is that as far back as we can trace it, the infant mortality in the Black community has been around twice the rate in the white community. And so even though both of those rates have come down very, very dramatically, and many more children are surviving in both communities. You still see that disparity, that the Black infant mortality rate in the United States is twice or more than twice the rate in the white community. That was true when we were talking about the difference between more than 100 out of every 1,000 babies and more than 200, and it's true today. We've come over the course of really the last century to think about infant and child mortality as a mark of how a society is doing, how a country is doing. We collect data around the world, we compare countries, and we use it as an index of how well a nation is taking care of some of its most vulnerable citizens. I want to move back from that current view to talk about a couple of the components of that high infant and child mortality that we saw in the 19th century and still at the beginning of the 20th, and to drill down a little on what happened, how were these issues addressed. So I'm going to talk first about a disease that I've never seen. I studied it in medical school. I know it's in the differential, but I want to talk about diphtheria, which is a bacterial disease. It's caused by a bacterium which produces a toxin. The toxin is what does the damage. It kills tissue, and that necrotic tissue and the debris contribute to building up something that's called a pseudomembrane, a blockage in the throat, although the toxin can also attack the heart and the kidney. It was a pretty common disease. Like many diseases which attack the airway, it was more dangerous in children because children have small airways, and that pseudomembrane used to suffocate children. In the 1890s, it was a pretty common cause of death in New York City, and again, most dangerous in small children with their small airways. So I'm going to tell you about 3 children over the course of this lecture who died of diphtheria. The first one I want you to think about is the child born to someone who is often described as the founder of American pediatrics, the father of American pediatrics, my field. There's a hospital named for him in New York. And he's also the person who wrote the sentence about pediatrics is not about dealing with miniature men and women. Children are not small adults. An essential principle in studying pediatric medicine. He had an interesting life. He was born in Germany. He was supposed to have been weak and sickly as a small child, which left him with a determination that we not look at children physically and try to predict who they will be. He was a revolutionary. He was arrested almost as soon as he graduated from medical school, charged with treason and sent to prison. He escaped from prison, went to England because he wanted to join up with Marx and Engels. They thought he was a little wild and suggested he go on to the United States, where he prospered and became the first professor of pediatrics, which was a word that he liked to use, at New York Medical College. He was related to Bellevue Hospital, which is part of our NYU teaching system, although it's a hospital that belongs to the city. It's the oldest public hospital functioning right now in America. And he was the founder and the first president of the American Pediatric Society. And here was his history in terms of marriage and children. With his first wife, they had one child who died at 1 day of age, and she then died from pregnancy complications. With his second wife, there were 2 stillbirths and 2 infants who died soon after birth, and also she had multiple miscarriages. He signed the death certificates of the children who died and diagnosed them both with weakness or debility. And then she died from nephritis following on a miscarriage. In 1873, he married another doctor, Mary Putnam Jacobi, who was a really remarkable figure. And one of the things in writing my book about this and researching this, really extraordinary characters. I'm going to try to tell you about some of them. She had gotten her MD in 1864, and then she was the first woman allowed to study medicine at the Sorbonne in Paris, though they made her use a separate entrance. And In 1871, she was elected to membership in the Medical Society of the County of New York, and the president of that medical society, Dr. Abraham Jacobi, said at that meeting, pointed out that this medical society of the County of New York had done something which most medical societies, certainly the national medical societies, had not done in opening the doors to worthy members of the medical profession, male or female, white or colored, and thus granted reality to the gospel of American citizenship. And remember, he was an immigrant, the Declaration of Independence, according to which we are all created free and equal. She did a lot of work on the diseases and the health problems of women. And what I'm trying to say is that these two between them knew an awful lot of medicine. They married in 1873. They had a daughter who died at 1 day of age of what Abraham Jacobi diagnosed as atelectus pulmonum from intrauterine respiration, probably what we would call meconium aspiration. Then they had a son, Ernst, in 1875, and Mary Putnam Jacobi wrote to her mother about her husband. The doctor's happiness in the baby is so intense as to be touching and almost awful. And then in 1878, they had a daughter, Marjorie. So Abraham Jacobi published widely, including in 1880, a massive authoritative treatise on diphtheria, which he had seen a great deal in his practice. One of the heartrending things in reading this treatise, there's a huge amount of clinical experience and clinical knowledge. The last ditch effort to keep children alive was to open their airways, to perform emergency tracheotomy. And he did it, he wrote, but the results were worse and worse, and there's almost no one recovers. And what he writes is that only the utter impossibility of witnessing a child's dying from asphyxia has goaded me on to the performance of tracheotomy. So you have there this extremely knowledgeable pediatrician, this founder of the field, saying, I'm doing this dramatic intervention because I can't watch children suffocate, but it doesn't help. They don't recover. So in 1883, 3 years after that treatise was published, both of the Jacobi children got diphtheria, and Ernst died at the age of 7 years, 10 months, and 7 days. So I'm not just saying to you that wealth could not protect a child, that power could not protect a child. I'm saying to you that you could be two incredibly knowledgeable, forward-thinking physicians, and you could not protect your child. Abraham Jacobi actually went on to publish this as a case study, not identifying it as his own family, and he identified the source of the diphtheria as the nurse. And many scholars have speculated that perhaps he worried, perhaps he agonized over the possibility that as a practicing physician, he might have brought the disease home, and came to this conclusion because he could not bear to think that. The other child I want to tell you about now is the first son of W.E.B. Du Bois, the pioneering sociologist, historian, civil rights activist, who in his 1903 book, The Souls of Black Folk, there's a chapter about the birth of his first son, Burghardt, which occurred when he had taken up a professorship at Atlanta University. And he wrote with great joy about the birth of Burghardt. So sturdy and masterful he grew, so filled with bubbling life. I too mused above his little white bed, saw the strength of my own arm stretched onward, through the ages, through the newer strength of his, saw the dream of my Black fathers stagger a step onward in the wild phantasm of the world. And there's the family photo of the three of them. And in 1899, at the age of 18 months, Burghardt came down with diphtheria, and he was very sick. We knew baby was sick. There was no white doctor in Atlanta who was willing to treat him. And his father wrote, 10 days he lay there, a swift week and 3 endless days, wasting away. Then the day ended not, and night was a dreamless terror, and joy and sleep slipped away. And they chose not to bury him in Georgia. So they carried him back to Massachusetts with his flowers and his little folded hands. And there's the grave in Massachusetts. His father wrote, "No bitter meanness now shall sicken his baby heart, till it die a living death. No taunt shall madden his happy boyhood." So what had happened by 1899 to make it even conceivable that there might have been a treatment? I'm going to tell you, 1883, the bacteria is identified. That's the year that the Jacobi children get sick. It's cultured. It's confirmed that it's the toxin that causes the diseases in 1888. And then in 1890, Emil von Behring, who is a German doctor, and Kitasato from Japan, together develop anti-serum. That is to say, they can immunize animals with a version of the toxin. And two French doctors, Roux and Martin, develop a technique to immunize horses and get the anti-serum. And then in 1894, they do an experiment. They give that antitoxin to 448 children in one Parisian hospital, and more than 3/4 of them recover, although 1/4 of them still die, whereas in the hospital where they don't use the antitoxin, more than half of the children die. It's presented in 1894 at a scientific meeting. And this is a description of the reception of this unbelievable first triumph of this relatively new science, bacteriology. Hats were thrown to the ceiling. Grave scientific men arose to their feet and shouted their applause in all the languages of the civilized world. I had never seen and have never seen such an ovation displayed by an audience of scientific men. So by 1899, this has become a question of where you live. Is there anti-serum there? And so there are actually two medical historian doctors went back and looked at the question of whether there was any anti-serum in Atlanta. And it's not clear that it was there. There was one doctor in Atlanta who had received a shipment at some point, but again, not clear where it was or who could get it. Whereas in New York City, in that summer of 1894, the chief bacteriologist of the New York City Health Department heard this news and reacted by setting up a stable in New York with a set of horses and making the antitoxin, the anti-serum, available through the public health system to everyone. So the conclusion was that in 1899, in many ways, similar to discussions we've had, it was your zip code. It was where you lived. If you were in Berlin, if you were in New York, there was serum available, and it was available in public clinics. In other cities, there was no serum, or there was serum only for the patients of particular clinics. The other thing that was happening right around the same time is people were figuring out how to intubate young children, how to put a tube down instead of having to do the tracheostomy. This is actually a teaching diagram for the intubation of, as you can see, a wide awake child. The anti-serum was a wonderful thing, but it wasn't a simple thing. It was a horse serum. Many children had strong reactions to it, causing something called serum sickness. It did not deliver lasting immunity. The antibodies worked for a little while, but it was hard to measure. And honestly, it didn't always work. I told you that even in that first experiment, 1/4 of the children died. That was a great victory, but it's a 25% mortality rate. So in 1913, you have the first development of antitoxin and toxin mixed together to develop a vaccine. And by 1921, it's being tested. And again, it's a public health intervention in New York, in which they test 180,000, they take 180,000 children, they test half of them, and anyone who is not immune is vaccinated. And then they have 90,000 who they don't test or vaccinate. And that group gets 4 times as many cases of diphtheria. So already by the 1920s, you have public vaccination campaigns going on in New New York in the schools. Here are the little cards that children get to show that they've been vaccinated. This should resonate with everybody with what we're going through right at this very moment. And here are the New York City school children lined up in the public school getting the vaccine from the school nurses. And this is, again, this is 3 decades earlier than anything that we think about with polio vaccine campaigns. The most famous episode in the history of defeating diphtheria is the dogs. In 1925, diphtheria breaks out in Nome. There's a doctor who had ordered the antitoxin, but it hadn't arrived, and the children start dying. And there are 20 confirmed cases, more children at risk, and they get the antitoxin by train as far as Nenana, and then for the last 674 miles, it's carried to Nome by teams of sled dogs with heroic mushers, heroic sled dogs. It's the trail that's run now for the Iditarod race, and that statue in Central Park of Balto, who was the lead dog on the last relay, is probably the most well-known souvenir of the battle against diphtheria. Although on the other side, you see Togo and his team, and there are people who feel that he was the more important dog because he was the lead dog on the longest part of the race. I'm going to say one more thing about diphtheria. This is from the Canadian Public Health Journal in 1927, a doctor writing about the change that had taken place during the course of those years, remembering the case of a beautiful girl of 5 or 6, the 4th child in a farmer's family to become the victim of diphtheria, who literally choked to death. And I felt, as did every physician of that day, as if my hands were literally tied, and I watched the death of that beautiful child, feeling absolutely helpless to be of any assistance. Then 10 years later, my own daughter became ill with diphtheria. To watch the choking, dreadful membrane melt away after the injection of antitoxin and disappear in a few hours with complete restoration to health within a few days was one of the most dramatic and thrilling experiences of my professional career. And again, that's a little piece of what you're looking here in this graph, a little piece of the science, the public health, the bringing down those numbers. I'm going to mention somebody who worked here at Bellevue in a similar connection, Dr. Edith Lincoln, who started the Children's Chest Clinic here, and she began signing up children. She would study tuberculosis in more than 2,500 children, many of them the children from the tenements on the Lower East Side. But what I want to emphasize is that she had no therapy to offer. She was studying them, she was watching them, but 90% of the children who died within a year of the first diagnosis, and that was 1 in 4 of the children with recent primary diagnoses. The babies died at higher rates. The children who got meningitis or miliary disease died at higher rates. There you see her sitting on an early Bellevue Hospital ambulance. And here you see patients up on the roof, tuberculosis patients, an adult patient up on the roof of Bellevue getting the air. And so she described the course and prognosis of tuberculosis in children. She did extensive research, but this is again someone who in her practice saw the drug arrive. In 1943, streptomycin was discovered, and by 1944, there was treatment for children in that clinic, and the survival rates for children with miliary tuberculosis increased to 96%, and they can even cure 85% of the cases. And this is, again, one of those scientific journal articles where the title is calm, but something really dramatic has happened. She, all her life, Dr. Lincoln was an advocate for the importance of making sure that people remember tuberculosis and be aware that wherever there are tuberculous adults, there are infected children. Again, the moral that comes up again and again when you look at the battle against infant mortality is you have to fight it everywhere. You don't keep your children safe by making your house safe. You have to make your community safe. You have to make the world safe. Last disease I want to talk about is cholera infantum, which is infant diarrhea, summer diarrhea. It's not cholera, but I want you to think about this quote, that more than a quarter of the children born in the civilized world of the second half of the 19th century, that is to say, the cities and the towns, of places that were urbanized, more than a quarter of them died before their 5th birthday, and nearly 1/2 of these deaths were caused by the summer diarrheas. The summer diarrheas are the cholera infantum, and nobody knew what caused it in the 19th century, and you'll see some medical writers thinking it's personal and domiciliary uncleanliness. That's why it's more common in the tenement houses and parts of the city occupied by the poor. That's not strictly true. It happened everywhere. And the main risk factor for it was children who were not breastfed or children who are weaned, remembering back to John Quincy Adams' daughter, in an era in which milk is not pasteurized and water is not absolutely clean, and animal milk is not tested for various pathogens. Weaning becomes a very dangerous age. And so I would just like to quote another one of my heroines that I loved writing about, Dr. Rebecca Lee Pumpler, the first African-American woman to earn a medical degree from the New England Female Medical College, who had an amazing practice history because after the Civil War, she went to Richmond, Virginia, and spent time practicing with a very large population of formerly enslaved people, then practiced in urban Boston, lived and worked on Beacon Hill, and wrote her book of medical discourses in 1883. So she's Jacobi's era. This is the same era that his kids, this is the year that his kids get sick. And she comments with a certain amount of irony that it's been argued authoritatively, no doubt, that the causes of cholera infantum, summer diarrhea, are poor milk, bad air arising from old water-soaked cellars of tenement houses, or, she points out, when it affects those of all conditions in life, the rich, the poor, the black, and the white, then its cause is said to be in some atmospherical phenomena. The medicine that was happening in the late 19th, early 20th century happened with a context of social justice, social context, especially when it was infant and child mortality. The book, How the Other Half Lives, published in 1890, was subtitled Studies Among the Tenements of New York, and was very focused on the question of living conditions, of how children were growing up, what were the conditions that were creating the kinds of medical problems and nutritional problems that people were seeing. The book Infant Mortality, a Social Problem, a pioneering book published in England in 1906 and then published in the United States in this edition in 1907, made the argument that infant mortality, it's not a question of individual people with bad habits, it's a social problem and it requires social solutions. And then the last of my heroines who I want to talk about is Josephine Baker, who was the assistant commissioner, who was the first director of the New York City Bureau of Child Hygiene. She trained at the end of the 19th century as a physician, and then in the 20th century, in the early 20th century, she got involved with public health. And her perspective, again, the summer diarrhea. Summer came, it got hot, milk spoils, there are flies, and the babies die. An average of 1,500 babies dying each week in the city, she wrote in her memoir. Lean, miserable, wailing little souls carried off wholesale by dysentery. Even New York's worst slums have now forgotten what dysentery epidemics were like, but we knew 30 years ago. And she tries an experiment in which she borrows the school nurses, because it's summer and school is not in session. And the nurses, remember, she's working without antibiotics, she's working without pasteurization. She's working without therapy for children who do get diarrhea, but they're emphasizing breastfeeding, ventilation, light clothing. And in that district where they're doing that, there are 1,200 fewer deaths than in the previous summer. Everywhere else, the death rate was unchanged. And listen what she writes. She writes, I had learned one certain thing. Heat did not necessarily kill babies. And this was news at a moment when it was not clear what was happening, but it was not inevitable. And here's her troop of visiting nurses from the Henry Street settlement on the Lower East Side, who are knocking on all of those doors. Here are the nurses from the Lincoln School for Nurses, founded in 1898 in the Bronx, because many nursing schools would not take African-American students. These nurses would go on to do amazing public health work, especially in the Black community, especially when it came to tuberculosis, which was a devastating disease in New York and Philadelphia in the Black community. Purified milk became a cause in the late 19th century with the idea that much milk was being adulterated. Nathan Strauss, who was a philanthropist, established milk dispensaries. Pasteurization would not become mandatory anywhere in the United States until 1908 and not until 1912 in New York. Here's one of his milk depots. Many of these actually went on to become public health clinics because parents were bringing in their babies and it was a chance to weigh them, measure them, as well as to disseminate pure milk, to publicize the idea that breastfeeding was much better than any other option for keeping children safe. And here's a relatively famous poster. You can see it takes a fairly stern tone with parents, telling them that certain foods will poison the baby. It's a Chicago poster. Here's another New York milk dispensary. And finally, here's a poster here from the Children's Year campaign in 1918. I like this poster because it's sort of positive, but I also think it carries with it certain ironies because in 1918, the world is at war. And one complicated piece of the battle against infant and child mortality has always been a little bit the question of whether different countries are competing with one another to lower infant and child mortality, in part to increase the workforce, increase the availability of future soldiers. I want to say one more word about the presidents of the United States, returning to my convenient sample of people who are without question well connected, starting with my third diphtheria death, Grover Cleveland, who actually served two separate terms as the 22nd and 24th president of the United States, had a daughter, Ruth, born between the two terms. And therefore, when he went back to the White House, she was a White House baby. She was known as Baby Ruth, and her every activity was chronicled in the newspaper. She came down with diphtheria in 1904. She had the doctors come. She got the anti-serum, all possible treatment, but she died 3 days later. So that's a 1904 death. It's really more a 19th century death than a 20th century death. But until you have the vaccine, there really is no complete safety. I want to tell you about Dwight Eisenhower's first baby. He was the president elected in 52 and 56, but before that he was the supreme commander of the Allied Expeditionary Force in Europe during World War II. His first son was born in 1917, Ike, and came down with scarlet fever when he was a year old. Scarlet fever is strep. It's the same strep that causes strep throat, but there are no antibiotics when this happens and the child dies. And Eisenhower, in his memoir, writes about the quarantine. He couldn't be in the room with him. Occasionally, they would let me come to the door just to speak to Ike. Ike held out for 10 days. The scarlet fever turned into meningitis, and he dies in 1921. So that's a pre-antibiotic death. So is this. Calvin Coolidge is elected in 1924. He has a son. He has two sons, Calvin Jr., who is playing tennis with his brother on the White House lawn. He gets a blister on the third toe of his right foot. It's a staphylococcal infection. It turns into a septicemia, a blood infection. He's admitted to Walter Reed, and he's dead within the week with, all of the most important senior doctors basically standing helplessly around his hospital bed. Coolidge wrote, "When he went, the power and the glory of the presidency went with him." And they're buried next to each other. And then last, and this is a death which was repeatedly cited during my own training, the only child born to a sitting president in the 20th century was the baby Patrick, born in 1963 to John F. Kennedy and Jacqueline Kennedy while they were in the White House. The baby was premature, born. The First Lady went into labor while she was vacationing on Cape Cod. Baby was delivered at an Air Force base and then rushed to Boston to the hospital where I trained. He was about 5.5 weeks early. He weighed almost 5 pounds. By today's standards, a very mature and large premature baby. But again, in 1963, there was no way to intubate him, no way to treat him, no way to prevent it, no way to ventilate him, and he died 2 days later. And this is a death that was cited to us repeatedly during my residency 2 decades later, when it was routine to be saving and ventilating babies who had been born 10 weeks early, 12 weeks early, even more. So I just want to reiterate that the cemeteries of the past are full of sad memorials to children who die, to families who lose more than one child, that this very stark graph represents a tremendous amount of progress and a tremendous decrease in grief and mourning in all communities, but that the disparities have persisted, and that when we look at our much lower infant mortality rates, we still see the effects of systemic racism, of poverty, of differential medical care, and that those disparities remain challenges in thinking about infant and child mortality today. The world does not look the way it looked in 1800, and I hope that hearing some of the stories of these particular families and particular children will help you appreciate both the progress that has been made as a combination of public health, medicine, hygiene, social justice, and advocacy, and also the distance that there still is to go. Thank you.